first we're inspecting, and then we're going to palpate and make sure there's no tenderness or masses that we can't see. And we're going to do you can do a whisper screening hearing test where you just say, repeat what I say.
99.
Okay, and you do it bilaterally.
98.
Okay. Or you can come behind her, behind your patient, and say, can you hear this?
Yes.
Can you hear this?
Yes.
Okay. So that's just another soft sound. So you can do either the whisper test or rubbing your fingers together. And that's just the hearing screening test. And then we're going to do the Weber test, which detects just conduction, where you strike the tuning fork against your hand, hold it in the midline, and ask, which ear do you hear that in? Both ears. Okay. And then the Renee is, can you feel this?
Yeah.
Tell me when you don't hear it anymore. Can you hear it now?
Yeah.
Okay. So that's air conduction is longer than bone conduction. That's how you test it. You don't hit it again. You just wait till it stops, and then can you still hear it? And that just proves that air conduction is longer than bone.
What type of hearing loss is caused by like repeated exposure to loud noises? Is it air or is it?
That would be sensorineural, I would think.
It's neurosensory, yeah, because
Yeah.
you're damaging the nerves.
It's
It's not a physical.
It's not a conductive loss.
Right. It's not scarring. I was just thinking how best to put it, but yeah. So it's in the nerves themselves, the receptors. If you use the higher frequency tuning fork, it doesn't last nearly as long. You're not going to be standing there for 10 minutes waiting for it to die down.
That one doesn't go as long?
Right.
That's what you said?
Yeah, they don't go as long.
So you like that one better? I don't know. This
I'm
one seems easier to
I'm
do.
lazy and I'm in a hurry. The other thing, instead of banging, because if you keep banging, eventually you're going to hurt yourself. You'll hit a carpal bone or
He likes
something.
to do this.
I just snap it. Just like snapping your fingers, but it works just as well.
So there's more than one way to do it.
There's more than one way to do all of this.
Yes. And you will find the best way for you. Try it both ways.
But
If
you're going to
you
do it our
think-
way
If you think
until
this is easier,
you're going to do it our way until you're out of here.
right. So either way works.
What?
And it
How
gets
you
it right.
strike it?
I would always do the Weber first.
Okay.
Yeah, which goes first? Yeah, we usually do Weber first.
Okay.
And then, because if it's abnormal, then you're going to concentrate more on the ear that's abnormal.
But for the test, we have to do both, even
Yes.
if the Weber is normal.
Yes,
We're gonna
because
do
you
both
want to
anyway.
show us.
Oh, okay.
You want to show us. We want to know that you know how to do it.
You did both.
Yeah.
Yes. Yes.
Yeah, absolutely.
Okay. So then we're going to look inside of her ear. So we're going to switch and put on the otoscopic head. And get one of the specula. Big one. Different sizes. The diameters are different.
Yeah, on purpose.
Right. So I like, the best way to hold this is down at the base, to hold it sort of upside down, and use this as, put your index finger down at the base, well, I don't use my ring finger down at the base near the head of the otoscope, and use this sort of as a fulcrum. You need to stabilize it on the patient's head, just in case they jerk towards you or away from you. You're not going to cram it into their ear canal, because that wouldn't go very well. So you're going to just put it in. You don't put it in very far, and you need to look in here as you put it in, and you can notice what the external auditory canal looks like. See the presence of any foreign bodies, any bleeding, any abrasions, any wax buildup, and then put it in a little bit further, and you can see the ear canal, and the eardrum, the tympanic membrane. See the cone of light. See the malleus. Notice the color is pearly gray. Nice light reflex. Beautiful eardrum.
When you're first starting, people have a hard time finding the eardrum. Okay? Swear to God. You wouldn't think it'd be hard to find. It's only there. The only thing there is a dead end, okay? But no, nonetheless, people have a hard time finding it. Look for the cone of light. you'll see that little flash. Just keep looking around till you see it, and then you know you're looking at the drum, and then you can figure out where you are.
For noses, you can leave this same speculum on, turn it up again, have the patient tilt their head back, sort of push their nose up in the midline with your other thumb, and then just guide your nose. You don't look through here. Just use this as a flashlight. But if you need to go in deep, you can have the speculum here to guide your way. And you can see the turbinates, the septum, notice any foreign bodies, drainage, discharge, bleeding, etc.
You could look through the back part, you're just going to get a really magnified view of nose hairs.
Good point. To percuss the sinuses, we have the frontal sinus up here, maxillary sinus here. You can tap on it. You can first palpate and push pretty hard and say, is there any tenderness when you push? Or you can percuss. If they're tender, if they're infected, that's really going to hurt. So you're not going to get away with doing that for too many times. But you can percuss with your other finger or just tap on the bone.
You have to tap hard enough so that you hear it.
Right.
You can hear it and tap hard enough.
Right. If there is some tenderness, you might want to transilluminate the sinuses. Can you get the light? Professor Burnham did this last time. It worked pretty cool. So we're going to go right up under the eyebrow and push, and then you can see right into the sinus cavity.
Light up like a pumpkin.
Right.
Wait, what? You put it right under the eyebrow.
Yeah, right under the arch.
Okay.
Yeah, where's the frontal sinus? It's right above the nose, right?
Yeah.
So you shine just sort of in an
Can you
angle.
do it on the other side?
Right about the hippocampus.
Oh, yeah,
Yeah, I shine.
Oh, just with the light up above it?
Yeah, that's what the sinus, that's what the
Yeah,
sinus
the
is.
hippocampus shines out into the mouth.
Or you can push here.
Okay.
If the and if it's like filled with something too.
And notice that the sinus, the maxillary sinus illuminates.
What
Where do you
what
do
about
the mouth
opening
one?
the mouth?
That's if you push here and have the patient open their mouth and you can see it.
For the ethmoids.
Oh, that's so cool.
If one is darker than the other, and that's where they have
You're like a
problem.
superhero.
That's the idea.
You're
Oh,
good
no,
with all
mine's,
kinds of
mine's,
eyes.
I'm all roided up right now.
Yeah, CT scan is
Oh,
really
roided
sensitive
up.
to sinusitis.
Okay.
Don't make her angry.
For the oral cavity, we're going to start by looking exteriorly at the lips to make sure there's no ulcerations, no cracking, fissures, bleeding. Then I'll say, open up your mouth, please. Get a pen light or a flashlight. With the tongue blade, you can just pull the buccal mucosa away from the gingiva and dentin and teeth so that you can see all of the gingiva and look for any evidence of plaques or white lesions, which may signify oral cancer, and look at all 4 quadrants of the mouth.
Especially in people who dip. Look at
Right.
their sulci.
Ask the patient to lift up their tongue so that you can look under their tongue. Notice the condition of the teeth and see if there's any missing teeth. Look up in the upper, at the hard palate, and then the soft palate in the back. Have the patient stick their tongue out. If they say ah, yeah, so she doesn't really need a tongue blade because when she lifts up when she says ah, her tongue stays down and her soft palate rises. A lot of patients' tongue rises when they say ah. So say ah again, and you can see the soft palate rising with the uvula in the midline. I do like to I like to grab.
You like to grab the tongue? Give you some God.
Yeah.
When we're doing our exams, are we saying